Momita, you mute everyone and start.
Okay, ma'am. A very good evening and warm welcome to all the dignitaries present here. I am Momita from Clinic, serving as the allocated session assistant to ensure a seamless experience. Clinic stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clinic serves as the digital partner for this event, hosted by Cancer Kids Strength of Smiles Doctors Network, Maharashtra. And the focus of today's session is the webinar 15, session 2, childhood cranial germ cell tumor. So let's begin without any much delay. Let's begin today's session, for which I would like to invite Dr. Nirmalya Pradhan sir to take over. Over to you, sir.
Yeah, thank you, Momita. So I'd like to start my screen sharing. Can you please stop your screen sharing so that I can start?
Yes, sir. I have already stopped the screen sharing, sir.
Just a second, yeah. So, very good evening to all. Am I clearly audible and my screen is visible?
Your screen is not visible yet, sir.
Already I have done the screen sharing.
No, sir. We are unable to see the screen.
Just a minute. Is it visible now? Yes.
Yes, sir. Please go on.
Yeah. So, very good evening to all. So, Ekatrasetu webinar series has been initiated by the Cancer Kid Association, and we are focusing on discussion of various childhood cancer, and we want to make sensitize and bring up to all our audience what are the things, basic things, and what are the advances happening throughout in childhood cancer. So today our topic of discussion is childhood cranial germ cell tumor. So our experts for today are Dr. Prakash Shetty, who is the professor in Department of Neuro-surgery at Tata Memorial Hospital, Mumbai. Next in expert is Dr. Vasudev Bhat, who is the professor and head of Department of Pediatric Hematology and Oncology at Kasturba Hospital, Manipal. Dr. Uday Krishna, who is the senior consultant in the Department of Radiation Oncology at Apollo Proton Cancer Center, Chennai. And Dr. Subash Reddy Doni, who is the associate professor at SBS Medical College, Mehboob, Nagar. Initially, he has been worked in TMH Mumbai and Homi Bhabha Cancer Hospital, Visakhapatnam. So, I would like to come to the topic. Today, we'll be discussing the management, diagnosis, and various aspects of clinical intracranial germ cell tumor. And it is a subset of extragonadal germ cell tumor which arises within the central nervous system without any evidence of primary tumor in either the testis or the ovaries. And typically, as we know, all the germ cell tumor, it is also occurs in the midline, and mostly it occurs in the pineal region and supraciliar region. Though very rarely it can happen in other parts like cerebral hemisphere, brainstems, etc. It's very rare brain tumor. It really constitutes near about 4% of primary brain tumor in children. But there are data from Japan and other Asian countries which have showed their series that the incidence of pediatric germ cell tumor in their cohort is nearly 10 to 15%, which is quite higher as compared to the Western data, North American and European data. And across the world, median age of diagnosis age in the second decade, Usually there is a male preponderance which ranges from 2:1 to 3:1 male to female ratio, and male preponderance is mostly seen in the pineal region tumors. And there are these discrepancies and these incidents and age-wise are probably due to the gender, the age, the geography, and in few cases, some syndrome like Klinefelter syndrome and Down syndrome are probable cause, but there are no definitive thing have been proved till now. So whenever a child presents to us any kind of brain tumor, we get all these symptoms like obstructive hydrocephalus, some gait abnormalities, some seizure. But there are few manifestations which are very much particular to the tumor of the pineal region and tumor of the suprasellar. These are not particular for the intracranial germ cell tumor. These are particular for pineal tumor and suprasellar tumor. Any tumor in the pineal region may present with obstructive hydrocephalus and signs of raised intracranial pressure. As the size increases, we may see the child going into neuro-ophthalmologic abnormalities, and very rarely we see endocrinopathies if it involves the pituitary stalk. And suprasellar tumor, usually they present with some kind of hypothalamic pituitary dysfunctions, which are the endocrinal disorder, mostly affecting the antidiuretic hormone and presenting with features of diabetes insipidus. And as the size increases, they also manifest ophthalmologic abnormalities, and usually they present with very chronic subtle symptoms. And usually suprasellar tumors, they present after a prolonged period, maybe after a few months or so. So whenever we get this kind of symptoms in a child, the next we think about the evaluation. And first of the evaluation is the radiological imaging. So now I would like to ask Dr. Subash, how are you going to evaluate a child with suspected pineal tumor or suprasellar tumor on clinical background? What are the modalities of imaging you would like to do, and how will you distinguish this thing?
Thank you, Dr. Nirmalya. Am I audible?
Yeah, you are audible. Please carry on.
Okay, thank you. Usually in this case, with this clinical background, first investigation ordered is computer tomography, CT. And mostly it is non-contrast CT to begin with. CT, because it is very fast and easily available compared to MRI, does not require immobilization for 15 to 20 minutes. We can you go to the next slide? Yeah. So this is a typical CT scan, non-contrast study. We see an axial and sagittal sections. Clearly, as the red arrows indicate, there is a hyperdense mass, well defined, in the region of the posterior part of the third ventricle, which corresponds to the region of pituitary, pineal gland, sorry. And we see that there is a central calcification. The pineal calcification is preserved. And as you see on the sagittal section, which is much more clearer that it's a pineal gland lesion. And due to the compression over the cerebral aqueduct, there is resultant hydrocephalus. And periventricular ooze, that is periventricular hypodensity, is seen first in upper hydrocephalus. So the next investigation would be an MRI, obviously. So we see here 6 images. We have T1, T2 flare. Then in the lower row there are 2 post-contrast images and 1 CT scan image. So if you see here, the most important image is in the lower 2 images, that is axial and sagittal post-contrast T1 weighted images. We see definitely there is a bright region in the bright lesion in the region of the pineal gland, that is enhancing lesion, and relatively circumscribed, causing mild hydrocephalus. And the same patient, the CT, we see that circumscribed lesion with a central calcification. So these findings suggest presence of a pineal mass mostly, Cranial Germ. Next slide. Yes. Another case, MRI, sagittal section on the left hand side. We see clearly that the arrow points to the suprasellar region. There is an enhancing mass which is very bright, and even in the pineal region also there is another lesion. So this is a dual masses are noted, and similarly.
Yeah, Dr. Subash, can you please just adjust your this volume or something? You are little bit low in volume.
Am I audible now? Is it better?
Yeah, audible. Please little bit be louder. Yeah.
Yeah. So the first differential, I would think in this case would be a pineal cyst. This is a case of the pineal cyst where the arrow points to a hypointense lesion with a thin soft tissue ring. It's not a solid lesion. There is no enhancement here. So the first differential would be a pineal cyst in case of a pineal lesion. Next. Yeah. This is a schematic.
You are not audible, Dr. Subash.
Right, then it is most likely a pineoblastoma.
Dr. Subash, can you please describe a little bit? You are not audible at the initiation. Please repeat.
Okay, we see two schematic graphic images of axial section brain, and we see the blue component is the pineal mass, and the black dots are calcifications of the pineal gland. So pineoblastoma displaces the calcifications to the periphery of the gland. However, germinoma, we see that the calcification is engulfed and is seen as a central region. So sometimes it is very difficult to differentiate on imaging alone between germinoma and a pineoblastoma. In such cases, the pattern of the calcification seen in the mass really helps us in pointing towards a right diagnosis. So we'll see the cases now. Next slide. Okay, this is a differential diagnosis of a germinoma. This is a very large mass compared to a germinoma previous case, and it's little bit more heterogeneous and has more mass effect compared to the previous mass. There can be areas of small infiltration of the adjacent brain parenchyma. Can you go to the previous slide, please? Yeah. So again, this is a case of pineoblastoma. We should always think about pineoblastoma when we are suspecting a germinoma. Next. Okay, another case, pineoblastoma. The mass is little larger at presentation, and these are all the MRI images. And the last one is a CT image, where you see the calcifications are scattered throughout the mass in the posterior to the enlarged ventricle. Next. Another case, what we see here is sagittal MRI of brain post contrast the T1 weighted image and coronal image. We clearly see the arrow pointing towards the suprasellar circumscribed mass, which enhances avidly, right? And the mass is almost homogeneous.
Recording in progress.
Sorry.
Yeah, you please carry on. Yeah.
Okay. Okay, this is a suprasellar GCT. Next slide. Okay, another case, little larger, suprasellar GCT. We see the arrows pointing towards the mass. The top row second image is the T2 weighted image, which is a good modality to identify the mass. And in the lower second image is a post contrast T1 weighted image. So basically, these germ cell tumors are extra-axial tumors, that is, they lie outside the blood-brain barrier. So they enhance avidly. That is what we see here, a very large supracellular mass, lifting the optic chiasma. We see that at the bottom of the mass, the pituitary gland is still preserved. So this is not a cellular mass, but a supracellular. Next. A close differential would be craniopharyngioma. Again, it would be supracellular mass. However, craniopharyngiomas would have calcifications also and cystic area. So that's the differentiating point. And if you see the fourth image, it's a sagittal post-contrast T1 weighted image. We see only rim enhancement, no enhancement within the lesion itself, suggesting that it is predominantly a cystic lesion and points towards craniopharyngioma. Next.
Dr. Subash, may I request kindly little bit louder, please?
Yes, yes. This is another differential diagnosis of a supracellular mass, supracellular GCT. This is a case of LCH, supracellular. The blue arrow points towards a very subtle lesion in the region of the infundibulum of the pituitary. It's a focally enhancing lesion, very subtle on T1 and T2 images. Very carefully watch. We can see that there is a focal enhancing lesion in the infundibulum. The typical sites are pineal gland and supracellular region. However, we may also see the GCTs within the ventricles and brain parenchyma adjacent to the ventricles, especially the basal ganglia and thalamus. And we see here that there is a focal lesion in the left lentiform nucleus, which is a GCT within the left basal ganglia. Next. As mentioned earlier, 10 to 15% cases present with drop metastasis. It's very important to perform a whole spine scan with post-contrast images. So these are the three sagittal sections of the spine. The first one is T1 weighted image. The second, the CSF is bright. So it's a T2 weighted image, and the third one is a post-contrast T1 weighted image. So this image has been put here to emphasize the importance of post-contrast image. If you can see on the third image, the blue arrow points towards a very small deposit on the surface of the spinal cord, posterior to spinal cord, and it's almost impossible to identify it on a non-contrast image. So make sure that we do a post-contrast image and very careful evaluation of the entire spinal cord and the entire dura, the extramedullary interdural space has to be performed in order to identify any subtle metastatic lesion. Next. Another example, this is the last slide. We see that the white arrows point towards extramedullary intradural enhancing lesions. There are multiple lesions of various sizes. So again, a case of intracranial GCT with spinal metastasis. So next.
Yeah. Okay. Thank you, Dr. Subash. So
Yeah.
now we understand that pineal region and supracellular region, germ cell tumor, these are extra-axial tumor, means they are outside the brain parenchyma and they are beyond the brain barrier. So they will uptake and enhance after contrast injection. And the close differential in the pineal location are the CNS embryonal tumors, the pineal parenchymal tumors, and very rarely ependymoma may occur in this region. And close differential for supracellular lesions are the Langerhans cell histiocytosis, which is very common in very younger age group, and other one is the cranial pharyngioma. And in either of the locations, the differentials may be the low-grade glioma, hematoma, and other metastatic disease from extraaxial tumor. So now in the clinical context of raised ICT and few of the either pineal region or suprasellar symptomatic child, we did a neuroimaging and we found out from our radiology friend that it is a tumor which is located in pineal region or suprasellar location, and probably they will say it is a germ cell tumor. We cannot differentiate between the various types of germ cell tumor based on neuroimaging only. Then we need further evaluation. Now I would like to ask Dr. Vasu, how will you go further from this point of clinical feature, radio diagnosis, looking at some pineal tumor or some suprasellar tumor, and mostly it is a germ cell tumor?
Yeah, thank you, Dr. Nirmalya. I hope I'm audible. So, whenever
Yeah,
we
you are
have
audible, please.
radiological features which are suggestive of a intracranial germ cell tumor, especially the location and when we consider the age, the first thing in the blood tests that we can do is just getting a serum alpha fetoprotein levels and a beta HCG. So, we have to be very careful while interpreting this. One, because of age, if we are dealing with a very young child, like an infant, then one has to be very careful because there are age-specific normograms for alpha protein level. But pre-operative, if there is an elevation in the serum AFP or beta HCG beyond, above the normogram, then it is along with the radiological finding, it could be diagnostic. And if the values are slightly higher than the cutoffs, then it is confirmatory that it is intracranial germ cell tumor, and that is a place where probably the biopsy can be avoided. For any reason, if the alpha beta protein or beta HCG is normal, but there is still a suspicion that it could be a germ cell tumor or a germinoma, then the CSF samples also can be tested. And generally, what we find, these are cutoffs which are there from the COG and from the groups. So, CSF and serum alpha protein more than 50 generally is considered as elevation, and CSF and serum beta HCG more than 100, again, millunits per ml is considered as significant. However, we must remember that in germinoma, pure germinomas, there may be a low elevation of beta HCG up to about 100, but when the values cross above 100, it's certain that these are secretory germ cell tumors, and these can be, diagnostic at times and can help in avoiding disease.
Yeah, exactly. So in pure germinoma, we may get a negative marker, but if we are getting an appropriate value of either alpha fetoprotein or HCG, we are quite pointing towards a non-germinomatous germ cell tumor. So next, in evaluation and diagnosis, to just complete, we should do one pituitary hypothalamic function proper evaluation so that we are not missing any major endocrinopathies which needs immediate correction. We should always do a visual field and acuity examination for suprasellar or hypothalamic tumor so that we can just assess it periodically to know about the progression of the disease and rapid rise in the size of the tumor. And baseline neuropsychological examination should be done after the symptoms of endocrine deficiency and raised intracranial pressure are resolved. And after this comes the role of the neurosurgery, and it is neurosurgery is not only a single point of contact. We require them from the initial diagnosis, initial control of various symptoms, to the definitive surgery, for second look surgery, and sometime in some what we call growing teratoma syndrome, their role is very important. So now I would like to ask Dr. Prakash Shetty, sir, what is the role of a neurosurgery team at the presentation of such child?
Thank you, Nirmalya. Am I audible?
Yes, sir, you are audible, sir.
So basically, when we see such patients, these are usually young patients who present to us, and when we look at the scans, sometimes we see the doubt for maybe a germ cell tumor, maybe because the tumor is sort of hyper dense, and sort of sometimes there is diffusion restriction with the solid enhancement. So in those cases, we have a doubt for that this tumor may be a germ cell tumor. So in case this patient has a tumor at pineal region, some of them may present with hydrocephalus and symptoms of raised ICP due to hydrocephalus. So before you could proceed with such cases, it is good to sort of resolve these neurological symptoms which occur. So depending on your setup and your expertise, if patient has hydrocephalus and if he is symptomatic, so at a tertiary center or a center which doesn't have endoscopy system, you could treat these patients with a shunt to relieve his intracranial pressure. And where centers which do have endoscopes, an option of endoscopic third ventriculostomy is possible in a pineal region tumor presenting with hydrocephalus. However, if the tumor is in suprasellar region, then this option is ruled out because that is a site where the ETV is done. So ETV can be done in pineal region tumors, but not in suprasellar region tumors where a shunt is an option. Now coming to the biopsy for diagnosis. So generally, our aim is to sort of distinguish the germ cell tumors from other pathologies, and also in germ cell tumor to differentiate germinomas from non-germinomatous germ cell tumors. So, so in these cases, as Dr. Vasu has said, we need to do the tumor markers. So if the tumor markers are normal, so it is an indication for biopsy. And if the germ cell tumor is high up on our list, then probably we should go in and take a biopsy. So the routes for biopsy, I'll come to it. So when do you not do a biopsy? So there are a few exceptions. So if the imaging shows a bifocal germinoma with a normal tumor marker, then you can proceed with further treatment. Doesn't require a biopsy for confirmation. If the patient has highly elevated AFP and HCG in serum or in CSF, as Dr. Vasu has said, then again, you could make a diagnosis of a non-germinomatous germ cell tumor or a mixed germ cell tumor. Sometimes you may have moderately elevated beta HCG levels. So these occur in cases of germ cell germinomas with syncytial tropoblastic cells. So in these cases, if you treat them with a tumor marker per se, and so there is a risk that you overtreat these patients of germinoma with a more demanding regimen for a non-germinomatous germ cell tumor. So this is the only hitch when you treat patients based on tumor markers. So also, if you are attempting a biopsy or if you are attempting to relieve the neurological symptom by endoscopic third ventriculostomy or ETV, then at that same sitting, you can do a biopsy. Also, it has been found that there is no role for gross total resection. Your aim is only biopsy in these cases, because 50 to 60% of these tumors are germinomas, which are extremely sensitive to adjuvant therapy. So you don't require a debulking surgery. And an exception would be if the histopath shows a mature teratoma, where you would go in again and remove the entire tumor, where a gross total resection is required. Next slide, please. So coming to the common sites and approaches. So about a third of tumor present in the pineal region, about 1/3 may present in the suprasellar region, and 1/3 present in the other sites. So if you have a lesion in the pineal region, which is tumor marker negative, so the approaches could be, open approach could be a supra or an infracerebellar approach, depending on the displacement of the vein of Galen by the tumor. So this vein of Galen is a deep vein. So basically, if the tumor, the pineal tumor displaces it upwards, then you have to go infracerebellar. And if the tumor is sitting on top of the vein, then you have to come above the, from the occipital region to get a biopsy, because you don't want to damage this vein. And damage can be the consequences of damage to vein of Galen can be sort of quite fatal sometimes, because you'll have increased cerebral edema all over. So I think this needs to be avoided. So basically, these are slightly challenging surgeries, even for biopsy also, and even to get the tumor out completely. Sometimes if the tumor is projecting from the pineal region into the posterior third ventricle, then you could do an endoscopic biopsy, and if there is hydrocephalus, you could do a third ventriculostomy also. Sometimes the tumor may not project into the suprasellar, but maybe in the floor of the third ventricle. So endoscopic biopsy can be performed in these cases. A tumor which is situated in the suprasellar region, the approaches for biopsy will be an open biopsy, which will be pterional, which is through the base of the skull, or you can come superiorly, which is transcallosal approach to reach the tumor. Next slide, please. So coming to the shortcomings of biopsy, because you are not sampling the entire tissue, so the results of the biopsy may be erroneous. So in some cases of mixed germ cell tumor where only one component may be biopsied. So suppose you get germinoma in the biopsy, which is a common feature in mixed germ cell tumor, you may be under treating this patient. So it is best to treat the highest grade tumor on the biopsy or on CSF or serum tumor markers to decide whether it's a non-germinomatous germ cell tumor.
Yeah, thank you, sir. So we understand now that there is a definitive role of neurosurgery team at the initial phase, just to rule out any hydrocephalus which requires intervention. There are various methods which sir has described, and for definitive tissue diagnosis. And based on this, the WHO has classified intracranial germ cell tumor, either germinomatous or non-germinomatous germ cell tumor, which consists of embryonal carcinoma, yolk sac tumor, choriocarcinoma, mature immature teratoma, and teratoma with malignant transformation, and mixed germ cell tumors. Interestingly, Japanese collaborative group, they have defined the good prognosis, intermediate prognosis, and poor prognosis groups, and they have put the pure germinoma and mature teratoma in the good prognosis, as these are very much curable with pure germinoma with radiation chemotherapy, or mature teratoma only with surgery. And as our histopathology classification varies, they have differentiated into intermediate prognosis and poor prognosis based on the treatment intensity and their outcome. So now, after getting a definitive pathological diagnosis, we would like to make a proper treatment plan. So initial phase in the 1990s, the treatment of germ cell tumor in children in the intracranial region constitute only by the surgery, but with evolution it incorporated radiation, and nowadays, after getting a long follow-up period of those children who were treated in 1980s, we found that there are problems with radiation. So chemotherapy has been gradually incorporated, and somewhere the surgery has been avoided to decrease the long-term side effects. So now I would like to ask Dr. Uday, how would you plan a treatment for a child with a localized germinoma?
Thank you, Dr. Nirmalya, for inviting me for this topic, which is challenging at one point, and it is also very interesting. So, as we all know, globally, am I audible?
Yeah, you are audible. Please carry on.
So globally, if I think there are a lot of students in the audience, so just to make them also make it a little more interesting, globally, if we see the way US or the North Americans treat germ cell tumors, the way Europeans treat germ cell tumors, the way the Japanese or the Asians treat germ cell tumors are quite different. Even in India, multiple institution prospective studies, maybe be it from CMC Vellore or Tata Memorial or AIMS. So what emphasizes is the management of germ cell tumor is a multidisciplinary approach. So right from the point of time, whether I see a new child with a germ cell tumor upfront, or a pediatric oncologist sees, or a surgeon sees, all of us have to come together, and multidisciplinary approach is very essential. So this picture or the slide, what I have put up here is to emphasize that over decades, the management of germinoma has evolved, like how you showed from surgery. Like Japanese, for example, they go radical and operate everything. For example, Masao Matsutani's paper from 1997 in neurosurgery shows that if you operate and remove most of it, the recurrences are very low, and the recurrences are predominantly craniospinal anywhere. And so they implemented craniospinal irradiation. So later, Americans and Europeans they were against it, and they said no, instead of doing a radical surgery, you can just do probably a biopsy, or even don't do a biopsy, you can radiologically, you can pick up if it is germinoma or a non-germinamatous germ cell tumor, and you can treat conservatively by doing very good chemotherapy and then do radiation. So over years, what has happened is three important concepts with respect to radiation therapy has happened. One is, can we reduce the volume of treatment? Traditionally, everybody got craniospinal irradiation. So can we divide this between germinomas and non-germinomas? Can we decide, or can we upfront see who requires only a focal RT or who requires craniospinal irradiation? And even among focal RT, can you just do only to the bed, or do everybody require whole brain RT, or in between, which is now optimal, which is called whole ventricular radiation therapy, because most of the recurrences happen in and around ventricle. So this is the preliminary concept. So in a germinoma, we may see little aggressive ones like those which are occurring near basal ganglia and thalamus, and not classically in pineal or suprasellar. There can be bifocal germinomas, meaning involving both pineal part and then suprasellar part. We can see very indolent and very easily manageable non-germinoma. There can be aggressive disease. There can be metastatic germinoma. So based on what we are looking at in the upfront setting in a multidisciplinary manner, our radiation, the volume of radiation and the dose of radiation and the technique of radiation, of course, now because proton therapy is available, we talk about technique. Otherwise, most of the institutions have been practicing very good IMRT or 3D CRT or whatever technique is available. So this graph, what I have shown, so the survival Kaplan-Meier graph shows that compared to CSI and some chemotherapy, if your chemotherapy is very good, or if your chemotherapy has taken care of most part of the work, then probably only a focal RT in terms of whole ventricular radiation alone in a localized germinoma, and whole ventricular radiation to some dose like 24 gray, followed by focal boost also in selective cases, is a viable option. And in a metastatic germinoma in the upfront setting, or in a secretory germinoma, like how you told previously, maybe they will require craniospinal irradiation to some particular dose like 24 gray, followed by focal boost. If you go to the next slide, can we go to the next slide, please? So like I have shown here, the volume of radiation has evolved from craniospinal irradiation, which is a very complex technique, not only for us, also for children to tolerate, versus just giving focal boost or something in between like a whole ventricular RT. This has shown significant impact, not only in terms of local control and survival. Their survival is significantly is not compromised. At the same point of time, the neurocognitive decline is children, because most of them are pediatric and adolescent children, is significantly preserved when you treat only whole ventricular RT compared to what happens when you treat whole brain or craniospinal irradiation.
So, am I audible?
Yes, audible.
Yeah, please carry on. Yeah, please. I got disconnected for few seconds. Thank you. Yeah.
So I explained that in a disseminated germinoma, when upfront there is disseminated germinoma, the decision is to give craniospinal irradiation. The doses have been modified from before, which is 24 gray CSI and then 16 gray to the tumor bed, versus total tumor dose in a germinoma is little less compared to what a non-germinomatous tumor needs, versus a localized germinoma, which is predominantly whole ventricular radiotherapy alone.
So now we understand that in a localized germinoma, if we are giving only chemotherapy, we may get a very nice and dramatic response, but they are going to develop recurrence in future. And definitely radiation therapy we cannot avoid in those cases. But to decrease the radiation dose, we give neoadjuvant chemotherapy. Now, I would like to ask Dr. Uday, how are you going to plan the radiation therapy for the kids who present with disseminated germinoma?
So like I told previously, disseminated germinoma is a little rarer situation compared to focal germinoma. So these children will invariably require craniospinal irradiation after they complete chemotherapy. There was a question in the chat box by Madam Dr. Patricia. She wants to know VP shunt or third ventriculostomy. Will our whole ventricular volume differ accordingly? I don't know if the volume differs based on whether it is a VP shunt or a third ventriculostomy, which is done upfront for a hydrocephalus. But in a disseminated germinoma, definitely irrespective of what the response to chemotherapy is, the children still require craniospinal irradiation. But the dose of craniospinal irradiation differs between whether it is germinoma or a non-germinomatous tumor. Germinomas are extremely sensitive, and so they just require 24 gray as against 30 gray in non-germinomatous tumors. And instead of giving whole ventricular radiotherapy, you can just do only the tumor boost, which is about 16 gray. So the total dose will be about 40 gray, and of course, this will be done after the chemotherapy is completed.
Now we understand that for a localized germinoma, we give 40 gray total, and it is either ventricular with a boost, but we don't do craniospinal irradiation. But for disseminated germinoma, definitely we have to give craniospinal irradiation. Now, I would like to ask Dr. Vasudev, what will be your chemotherapy plan for the neoadjuvant in these children with germinoma?
Yes. So when it comes to a germinoma, like they mentioned, it is the combination therapy that has worked the best always in terms of outcomes as well as long-term outcomes in terms of cognitive and late effects. So generally, a combination chemotherapy again is used, and most of the times the active agents that can be used include carboplatin, etoposide, and ifosfamide. So when we mention this, it is important to again from which location these tumors are arising from. Like for example, if you have a supracellular germinoma, you may be having other problems related to sodium, and maybe giving ifosfamide in these patients may be quite detrimental because of the SIDH and a lot of sodium shifts that can happen. So generally, we prefer to give carboplatin etoposide because both do not require a lot of hydration. Carboplatin versus cisplatin. Cisplatin give a lot of hydration, pre-hydration, post-hydration, which can cause a lot of sodium shifts. So the first cycle generally, especially for a supracellular, preferably can be carboplatin and etoposide, and then subsequently, once there is a shrinkage when the sodiums are better, then one can consider adding uh, ifosfamide. So generally, 2 drugs are sufficient, 4 cycles, then reevaluate and then plan for RT when it comes to a germine. When it comes to metastatic, again, as Dr. Uday mentioned, if you use the chemotherapy first and reduce the tumor, there is a possibility that you can reduce the dose of 30. Conventionally, higher doses of CSI, when used, have shown similar outcomes. But in a child, when it comes to a child, when we are looking at late long-term effects, it's always better to give probably a chemo first, then reevaluate, and then one goes for a. So just to summarize, for a germinoma, if it is a non-metastatic or a bifocal, uh, generally 2 drugs per cycle, 4 cycles. Avoid ifosfamide initially, first cycle, when it is a suprasellar germinoma. Reevaluate, followed by whole ventricular RT and to the tumor. If it is a metastatic one, again chemo followed by reevaluation and then the
Yeah,
radiation,
thank you,
which is
Vasu.
craniosacral.
So we understand that this child either may present with some kind of endocrinopathy involving the antidiarrheal.
Hey, Nirmalya, you're not audible.
Dr. Nirmalya, you're not audible.
I think till Nirmalya joins back, I can just probably take the question from Swaminathan, who has asked how do you follow up a child for vision and how frequently and outcomes with respect to vision. So generally, when it comes to a tumor which is located in the suprasellar region, we can have issues secondary to vision. And again, it is sorry. So again, vision can actually be a problem when it is due to raised intracranial pressure leading to papilledema. So if it is secondary to that, then if you take care of the raised intracranial pressure, then the vision problem gets better. But if it is secondary, say the suprasellar lesion, then one needs to monitor closely. Having a baseline vision assessment is always very useful because you can always determine what is the improvement that has occurred secondary to giving the therapy and whether there is any vision, what is the perception of light, etc. And we must remember these tumors are not like optic pathway gliomas, low-grade gliomas, which will be persistent, which can grow after some time. So in case in these tumors, suprasellar germinomas, you can just do a baseline and then subsequently evaluate the vision.
Extremely sorry, there are some connectivity issue is going on. Is my screen is visible?
Yes, but it is showing not showing the presentation.
Is it showing now?
Yeah, now it is showing.
Yeah, please carry on. Sorry. Yeah.
So I hope I answered your question.
Yeah. So now I would, Dr. Vasu, can you please just let us know how will you plan for a recurrent germinoma treatment plan along with your colleague of radiation oncology? Just can you please describe how are you approaching the child with recurrent germinoma?
Yeah, so whenever we see a child with a recurrent germinoma, I think again your slide is not visual seen, Dr. Nirmalya. Yeah, now it's seen. So we always have to see what treatment this child has got previously, whether it is only the whole ventricular RT, whether it is a craniospinal radiation, whether this child has received chemotherapy in the past or not, whether the current recurrence is inside the radiation field or it is outside the radiation field. how early this child has relapsed, whether it is during treatment or immediately after the treatment is done. So generally the principles are that if the whole ventricular artery is given, you can actually salvage them with craniospinal irradiation. And generally, because these are germ cell tumors per se, they are extremely chemosensitive, and one can try salvage chemotherapy also. And if it is a recurrence which is outside the radiation field, then definitely it is craniospinal irradiation. But within the radiation field, after a gap of more than a year or so, you can again try to induce a CR or at least a near complete response, followed by radiotherapy again. And surprisingly, the outcomes are a bit better in this germinomas if they have relapsed. And regarding the radiation plan, I think Dr. Uday can mention for the relapsed one.
I agree with you, Dr. Vasu. In interest of time, let us go ahead with further slides because I think there are many more slides. The radiation doses we can discuss further. Dr. Nirmal will go ahead with the slides.
Is it visible now? There is some connectivity issue is going on.
No, sir, slide is not.
Slides are not visible. We
Is
can
it
hear
visible
you.
now?
Not yet.
Some connectivity issue is it visible now?
Not yet, sir. The screen is not visible yet.
Dr. Vasu, do you have presentation?
Yeah. Just check what is happening. मुझे पता नहीं. Is it visible now?
Yes,
Yeah,
sir.
it's-
It's visible now.
Hello. Is it visible?
Yes, it's visible.
Yes, it is visible.
Is it visible now?
It is visible now, Dr. Nirmalya.
Is it visible?
Yes,
Yeah,
it
it
is.
is.
Yes, it is.
It is visible. Let
Yeah,
us go to the next slide. We have completed this. Let us go to the next slide.
So, Dr. Uday, can you please just tell us briefly about the doses of this GCT germinomas, which
Yeah, so I was like in concurrence to what Dr. Vasu was telling. It depends on when the child was treated previously, what was the volume of radiation given previously, what was the dose given previously, and where is the recurrence now, what is the extent of chemotherapy which is given, and what is the response to that chemotherapy. So there are multiple factors to be taken into consideration. In interest of reducing the toxicity as much as possible, we would try to keep the volume of radiation as less as possible and treat probably as a focal radiation. Of course, if there was a CSI dissemination, even in the recurrent setting, then we have to give craniospinal irradiation once again, but which is very challenging to treat a child. I suppose that the child may have had craniospinal disease before also. If suppose it is a focal recurrence, like a recurrence in the pineal area or in the basal ganglia area or in the suprasellar area or anywhere along the CSF, then we have to devise our radiation plan as per that.
yeah, thank you. Now we would move to the next segment is the management of the non-germinamatous germ cell tumor. Already we have discussed the various types of non-germinamatous germ cell tumor. These are quite different from the germinomas in a way, like they present with some kind of elevated tumor markers either in CSF or in blood. these are less common as compared to germinoma. They constitute nearly 1/3 of the total germ cell tumor in intracranial region. And it requires definitely multimodal therapy. And even with multimodal therapy, their outcome is poor as compared to the counterpart, the germinoma. So now I would like to ask Dr. Prakash Shetty sir, how are you going to manage a mature teratoma which you have diagnosed initially on the biopsy?
So if your biopsy turns out to be, I think we have moved ahead. So if your biopsy turns out to be a mature teratoma, then probably the radiation or chemotherapy is not advised. You go in again and try to resect the tumor out. So the modes could be similar as what I have said before. So it is usually an open approach. So either approach to the pineal region or to the suprasellar region, and try and resect it out completely so that the patient does not require any further treatments. So you may have some recurrences occurring, maybe if you have not completely removed, but then these patients need to be kept on follow-up. So they may have a recurrence maybe after a long period of time also. Yeah.
Yeah, thank you, sir. So now, after getting this mature teratoma over, I would like to ask Dr. Vasudev, the rest of the tumor in the non-germinomatous germ cell tumor category, they require multimodal therapy. Definitely, they require some kind of chemotherapy, radiation with or without surgery. So how are you going to plan out this thing?
Yeah, so again, generally having neoadjuvant chemotherapy will kind of help to reduce the RT doses. Generally, craniosmal irradiation is what is required, and there are studies which are looking at probably giving only local radiotherapy also. However, that is in a clinical trial setting. But generally, the chemotherapy that is used maybe a 2-drug or a 3-drug regimen. In adults, commonly BP protocol is still being given by adult oncologists, but for a child, generally a combination of ifosfamide, carboplatin, etoposide is preferred. And 4 to 6 cycles, depending upon, if you're using a 3-drug, like for example, there are some centers which prefer to use all the 3 agents, so ifosfamide, carboplatin, and etoposide. So then it will be only about 4 cycles. Or there are some centers which do only 2 drugs, but they may do about 6 cycles in total. But again, it is important to evaluate after say 4 or 6 cycles for any residual tumor for a second look surgery, which will help in reduction in use of radiotherapy in the focal area. But by and large, most centers still prefer to give craniosmal irradiation for the non-germinomatous or the secretory germ cell tumors, because it is seen that the outcomes of these tumors are generally inferior compared to germinals.
Thank you. So now I would like to ask Dr. Uday, how are you going to plan the RT in non-germinomatous germ cell tumor, and what are the major differences between the RT planning of germinoma and non-germinomatous germ cell tumor?
Yeah, so the recurrence patterns has come predominantly from Japanese series Masao Matsutani group, and then they show that non-germinomatous has got more CSF dissemination compared to germinomas, and predominant recurrence patterns in germinomas is whole ventricular around the ventricles. So that is why the disease is the not to create more failures by giving only focal radiation, and not to give toxicity by treating whole brain or CSI. For germinomas, the plan of treatment is to give whole ventricular radiation, which is more or less standard of care now. And I don't think there are more modifications to it at present, at least. And in non-germinomatous germ cell tumors, of course, they are more aggressive, and usually they require cranospinal irradiation. So the doses of radiation in non-germinomatous germ cell tumors is we give about 30 to 30 gray of cranospinal irradiation at a little lesser dose per fraction, like 1.7 or 1.6 gray per day, so that there is no toxicity because of radiation therapy. And these are predominantly children and adolescents, so you don't want to give them added toxicity to whatever they have received by chemotherapy before. And followed by this, you give a tumor boost based on whether it is suprasellar or it is pineal, although we know most of the non-germinal matters predominantly are suprasellar. So most of them will get cranospinal radiation to a dose of 30 gray, and followed by boost radiation of about 20 gray to the tumor bed area.
Okay, thank you. So we understand that non-germinative germ cell tumor, they require little bit of more intensive chemotherapy in neoadjuvant setting, and they require little bit of more higher doses of
I think we have lost Dr. Nirmalya.
Nirmalya, are you there?
So I'll just share the screen. Maybe Dr. Uday can probably.
So with, I think this is the last slide, what he wanted to show.
Yeah.
For the non-radiation oncology colleagues, I'm sure all the radiation oncology colleagues, most of them, I see that many seniors are there in the audience as well. So they all may very well know the advantage of proton therapy versus conventional radiation. For the non-radiation oncologists, I would like to show there are 4 or 5 different images in this. It's a little busy slide, but I could not put more slides. That's why I made it as one. The figure 1, where you can see the yellow area with the blue background, white background area, is a single dose, single graph, wherein you can see one graph which is via photon depth dose in the tissue versus proton depth dose. All the yellow area, what we see is estimated. It is an estimated graph. It is not an absolute graph. Estimated that there may be extra unwanted radiation, which is because of the low dose areas which are treated proximal to the what proton graph can do. And then the distal yellow area is the low doses which are beyond the proximal are the high doses areas which are more compared to a photon, and then the distal are the low dose areas which are which the about the child or adolescent or a patient who with